guest here, Dr. Casey Grover. He is an emergency medicine physician and an addiction medicine physician, and we will share more about that in just a moment. The way that we start every podcast is just with a few rapid fire icebreaker questions. So we'll start. Number one would be, what is a fun fact that would surprise maybe your patients or your colleagues about you?
How about myself, my wife, and my daughter? We are all third-degree black belts in Taekwondo.
Okay, that is very surprising and really cool. That's awesome. And then my second question would be, let's say you're doing an ER night shift. If you, number one, do you drink caffeine? And number two, if so, what's your caffeine drink of choice?
That's a really interesting question. I don't know any physicians that work in the emergency department that don't consume caffeine because it's so disruptive to your sleep schedule. My preference is
Yes.
coffee in large quantities.
Okay, I like that. Black coffee, or do you have a specific coffee order?
We are actually vegan, and so we use cashew milk.
Okay. Okay. Awesome. That is great. And then the last one would just be, what is a skill that you've learned outside of addiction medicine that you feel has helped you in your practice?
In terms of treating patients with addiction,
Yeah, just in general, what do you think? Is there a skill that you've learned outside of medicine that just you feel like has made you a better physician?
um, I'm going to say CrossFit, and I'll explain why.
Okay.
So, as a part of treating someone with addiction, we have to help their brain heal, and exercise helps the
Hmm.
brain to heal faster. And we actually
Yeah,
have a program with my practice where my patients can come do CrossFit with me. So, on Wednesdays and Thursday
that's really
nights,
cool.
we do CrossFit. My wife is the other addiction doctor in the practice, the very lovely Dr. Reb Close. So, Dr. Close and I did CrossFit
Awesome.
last night with one of our patients. And it's really cool because CrossFit's all about the tribe. You get in there, it's the people you know,
Hmm.
it's a lot of fist bumps and high fives, there's loud music, and it's such a supportive environment. And as addiction is a disease of isolation, community is
Hmm.
really important. So CrossFit has made me a better doctor.
That is an amazing answer. I love that. I did CrossFit one time. My friend brought me to her gym, and I think I was seeing stars because it was such a difficult workout. Have not gone back, but it was a great experience. And I work out a lot. I thought I was very fit, but that was a really humbling experience for sure. But
CrossFit is a different level of fit.
yes,
Yeah,
definitely. I love that though with the community aspect, and that's so cool that your patients get that opportunity to work out with you.
so fun.
Yes. Well, we will jump right in. I would love just to hear a little bit about you, your background, and kind of what led you to this work.
So I initially picked emergency medicine as my specialty of choice. So when I was a medical student at UCLA, the first week of medical school, I wanted to see what was going on at the hospital. So I asked if I could tag along in the emergency department. And I saw the emergency resident take care of a suicidal child. She was 12, a very manic man who had bipolar disorder that was untreated, and a gunshot wound to the head, all in about 2 hours. And I thought to myself,
Wow.
holy smokes, that doctor can take care of any patient, anytime, anywhere. And that's the mantra of emergency medicine. So I was hooked and I was ready. Emergency
Hmm.
medicine, here I come. That summer, I got married to, as I mentioned, the very lovely Dr. Reb Close, who was an emergency physician. And so
Hmm.
I looked up to her as a good physician. That she's ahead of me. She's 11 years older than me, so she'd already completed residency and
Hmm.
medical school when sorry, actually, she just called me.
No
uh,
worries.
so she'd already completed all her training
Hmm.
when we met, and so I loved to hear what she was doing and get to hear what the patient she was seeing. And again, that mantra: any patient, anytime, anywhere. And so I jumped headfirst into emergency medicine, and unfortunately, I have been diagnosed with post-traumatic stress disorder from all the horrible things I saw and took care of in the last 14 years of my life as a doctor. And
Wow.
one of the things that contributed to my post-traumatic stress disorder was a feeling of helplessness, that the emergency department's a bit like America's storm drain, right? When it rains,
Hmm.
everything flows into the storm drain. And that's
Yeah.
society in America and the emergency department. So if there's a
Hmm.
person with dementia and their family can't take care of them, they take them to the emergency department. Was I trained in the management of chronic dementia? No. People have chronic abdominal pain and have seen 6 specialists and come to the emergency department angry that there's no help for them, which I respect. And I felt so
Mhm.
helpless. I couldn't help them. Patients had addiction. We'd see overdoses. I watched people die of alcohol addiction. And I felt so helpless that I was trained for emergencies. And yet most of what emergency physicians see are not emergencies. They are chronic illnesses without solutions and society's ills. And I journal every
Yeah.
morning. And one morning I was out for a walk with my dog and I was reflecting back on my experiences in the emergency department, and my PTSD really flared. And it was around a patient who got so angry with me that I couldn't fix her chronic problems. It felt like a personal attack. I mean, I went to UCLA for medical school. I trained at Stanford. I tried my very best to be the best doctor I could, and yet I was so inadequate for this patient. And it just really cut to my core
Hmm.
when that experience happened 5 times a shift for 14 years. Now, granted, my
Yeah.
post-traumatic stress disorder is from the 19-year-old who hung herself. I get flashbacks of her a few times a day sometimes. The young people who died in cardiac arrest, the young man who fell off his motorcycle and his arm was amputated by the accident, and the paramedics brought in his body and his arm in separate packages. But the
Hmm.
helplessness really, really got to me. And so
Yeah.
my spouse and colleague had started to work on not giving everyone opioids back in about 2010 before people realized opioids were a problem. And we started trying to
Hmm.
we tried to start moving away from opioids and treating pain. And so we got into this space around alternatives to opioids and preventing overdoses and handing out naloxone. And we finally had this aha moment of we would do so much more as doctors if we learned how to treat addiction. So we did.
Yeah.
We found that in Monterey County, where I practice, if you had Medicaid, there was really no option to get treatment for addiction, minus going into a residential treatment program. And we've found
Hmm.
this patient population that really had no other access to medications for addiction. And we are doing our very best and enormously grateful to be able to do this work. And my wife left the emergency department during COVID. It really was very challenging for all healthcare providers
Hmm.
during that time. And she had wanted to do more work in addiction, and COVID was just, okay, I'm done. And so she's been doing addiction full time for about 4 years. And I still practiced in
Hmm.
the emergency department until last year. And then because of my PTSD, I had to leave. So I've been doing addiction full time for
Hmm.
just a few months, but I've been doing addiction medicine for about 4 years as well. Sorry, very long answer. I apologize.
No, I really appreciate that and your honesty, about the PTSD. I really resonate. I am a nurse by training, started out as a CNA, all the things you do when you're trying to go to nursing school. And I really resonate with, I used to be a patient sitter for the suicidal patients. And I also had a patient who had wrapped a pulse ox cord around her neck in front of my eyes, and that will never leave me. Like that, I just will always carry that with me. And then I also worked in adult oncology, and I started my nursing career during COVID. So,
Mm,
really, really terrible time to start out as a new grad, and really resonate with, feeling hopeless because we were so understaffed, and I felt so bad because these people were in the worst pain of their life, and I simply didn't have the time to care for all of these patients. So, it's really difficult. It can be rewarding though in the healthcare space. So I'm really glad that you kind of found that avenue of addiction medicine. And I was reading about your background, and I saw that you had almost no training for addiction medicine in med school. So how did that realization hit you once you were in the ER?
So, one point before I answer that question, as many as 40% of healthcare providers exhibit symptoms of PTSD post COVID. So this is a big issue.
Yeah.
Okay, so yes,
Hmm.
I mentioned my better half, the lovely Dr. Reb Close. She attended medical school at UCLA and did her residency in emergency medicine at UCLA. And I attended medical school at UCLA and did residency at Stanford. So some of America's best medical institutions. In 15 years of medical education, we got 1 hour of training on addiction between the two of us. And believe it or not, it was
Wow.
for me in medical school and it was on gambling addiction. So essentially, I
Interesting.
learned everything from my patients. So I was
Hmm.
working in the emergency department, and you may remember this in your clinical career, but I always remember what
Yeah.
room people were in. So a young
Hmm.
man named Paul Harper was in room 34 in the emergency department. And I
Hmm.
walked in, and he had an abscess on his arm. And I was like, hey, I'm Dr. Grover. Nice to meet you. And the first thing
Hmm.
he said to me was, no opioids, and my name is Paul. And I was like, no opioids. We can be friends. So as you
Yeah.
probably know, lancing an abscess is a time-consuming procedure. You have to numb them up with lidocaine and make sure their anesthesia is adequate, and then you have to, incise the abscess, deloculate it, pack it. So it's maybe 10, 15 minutes. So he started
Hmm.
just kind of freeform talking to me while I was working on his arm, and he was telling me about his addiction, and he was sober. And I said, I'm working on trying to not prescribe opioids, and I don't know a lot about addiction. If I bought you coffee, would you teach me about addiction? And he said, sure. So we
Yeah.
exchanged phone numbers, and I went to a local place where they serve coffee, and I said, can you tell me about your life story? And he said, Doc, it'll only take me about 15 minutes. And he literally had handwritten notes on a piece of binder paper in like all different directions. So he'd like have it this way and then turn it that way and then turn it this way. And he spoke to me for 2 hours. We went back and got coffee a second time. He spoke for 2 more hours. And then we came back a third time and he spoke to me for 2 more hours just about his life story. And he unfortunately
That's amazing.
died from an opioid overdose in 2019. And I spoke at his funeral. And his art is the podcast icon for my podcast. And in almost every lecture I give, I show his art because I promised his family
Hmm.
that his death was not in vain. And I actually saw his mother
Hmm.
about 6 months ago. She brought me in the original painting of the picture that is my podcast icon. I have my own addiction podcast called Addiction Medicine Made Easy. And Paul and I wrote some articles together. If you search his name and my name, we actually published some articles about his experience with addiction and what I learned. And it's
Hmm.
people like that that have taught me. And so I came to addiction strictly from talking to folks like Paul. And what's interesting about Paul,
Yeah.
excuse me, is Paul was a fairly normal kid, liked to skateboard, liked to trampoline, liked video games, fairly similar to me. And at
Yeah.
18, he suffered a major burn and needed skin grafts. And he got morphine when he was in the burn unit. And
Hmm.
every time I tell this story, everybody thinks that's how he got started on opioids. And he actually
Hmm.
disliked morphine and did not take opiates after his burn. His addiction started later. There were some major issues. Something happened with his family, and I don't know all the details. But he came to alcohol, stimulants, heroin years after that burn. And that's what was so interesting to me. You have a molecule, morphine, that at one point in his life causes dysphoria and he dislikes it. And at another point in his
Yeah.
life was so intensely euphoric that he would do almost anything to get it. And that was an aha moment
Yeah.
for me when I realized that addiction was a lot more complicated than I realized. So I've spent about the last 7 to 8 years learning about addiction. That's one of the reasons I started my addiction medicine podcast is I had questions and I didn't know how to answer them. So I figured the best way to learn a topic is to get enough knowledge that you can teach it back. So I was like, how do you use
Hmm.
baclofen for alcohol use disorder? Let's put together a podcast episode. So it's interviews, it's going to the National Library of Medicine, reviewing scientific journals, it's patients telling me their stories, but it's basically been a journey over time. And now really my niche in addiction medicine is the intersection between trauma, PTSD, and addiction.
Wow. That's an amazing story. And I'm so glad that you can just continue to share his legacy. That's beautiful. I'm curious, is there like one lesson in particular? There's probably a lot of lessons that he taught you, but is there like one lesson that you feel like stood out the most from knowing Paul?
100%. So I go to a lot of schools. So I do education on addiction
Hmm.
professionally. That's one of my things I do when I'm not seeing patients. So I spoke to over
Hmm.
5,000 students at nearly 30 schools in 2024. So if I go to any fifth grade class in America and I ask the kids, what do you want to be when you grow up? A firefighter, social media influencer, a nurse, a doctor, a teacher, an astronaut. No child says addicted, homeless,
Hmm.
incarcerated, having overdoses. That's not part of anyone's plan. It's very easy to look at addiction and judge. And I can explain why we do judge, but it's so easy to look at addiction and judge. And yet we have to realize no one had addiction on their life goals. There's a great question
Yeah.
that I often ask myself as a healthcare provider, which is when I'm having a moment where I feel like I'm judging a patient, is I have to remind myself the
Hmm.
question is not what's wrong with you, it's what happened to you. And that goes back to
Hmm.
Paul, right? He wanted to make skateboarding videos
Yeah.
on YouTube, and yet he ended up being in and out of jail, in and out of being homeless, and addicted to all sorts of stuff. That was never on his plan. And again, he had some sort of traumatic incident in his life that led to some significant family conflict, and then he was homeless. And I never got a chance to talk to him
Hmm.
about his trauma, but I have so many of my patients that are victims of sexual assault for as long as they can remember. Some of my patients don't actually remember when when the sexual assault started, only that it stopped at some point. As I dig into my patients' histories, almost all of them have trauma. So that's the question. That's what I
Yeah.
learned. Addiction is not anyone's life
Hmm.
goal. We have to understand the life story that leads them to addiction, and that's part of the treatment.
Yeah. And my guess is that your answer would be yes, but are you a big fan of therapy to address the trauma behind the addiction?
Yes, and the reason I say that cautiously is it's sometimes hard to find the right therapist for a person. Here's how I explain it to my patients.
Absolutely.
Therapists are like car models, and I don't want to downplay the importance of a therapist. It's just a way to understand it, right? So let's imagine that
Yeah.
you and I go to a car dealership and we want to buy a car, and they offer us a Honda Accord, and we're like, I
Hmm.
drive it. It's not exciting. I don't like the way the review mirrors are. We don't give up on cars. We ask for a different model. We ask for a different make. I want to try out the Jeep truck. You want to try out the Lamborghini, right? Therapists are a little bit
Hmm.
like that. Each of us has our own individual preferences and our own individual way of processing things, and we therefore are the same with therapists. So I say yes, but not everyone's a good fit with therapists right away, and sometimes people get frustrated. And when I give them that car
Hmm.
analogy, it makes sense to them. I'll give you a personal example. My hospital, thank you, Montage Health, signed up for free therapy for all of our doctors. So I was like, sure.
Hmm.
I was chief of staff at the hospital and wanted to lead by example. So I signed up for free therapy from the hospital. My first therapist, lovely human being, wanted me to work on my inner child. It was just not working for me. I couldn't figure out the inner child thing. Lovely human being, very knowledgeable. It was not working for me. So I switched. My current therapist is great. I really like
Hmm.
how she approaches things with me, talks through things with me, and handles me very well, given that I'm very aware and in tune to mental health, given what I do professionally. She's great. So,
Yeah.
same thing. I would love all of my patients to have a therapist. It's just sometimes there's limitations on insurance. And I've got a couple of patients that have been looking for a therapist that takes their insurance for like 18 months and haven't found one, which is very frustrating because, yes, all of my patients need to process.
Hmm. I do like that, analogy though, because sometimes you do have to try out a few to kind of find the one that works for you and just find someone that you feel comfortable speaking to.
Well
So
said.
I appreciate that analogy.
Hmm.
And I would love to go back to the point that you brought up about why do we judge? I'd love to hear your thoughts on that.
So, I consider addiction a disease of executive functioning. So, what is our executive functioning? It's kind of the most complicated decision making, processing, thinking that we do, right? So, managing a
Hmm.
schedule, impulse control, weighing out what's a good decision and what's a bad decision. That type of reasoning and functioning is impaired in addiction. So, the way addiction works in our brains is the most human part of our brain is the prefrontal cortex. So, if I asked you to define the word hope, that's the prefrontal cortex, right? That's higher level reasoning. In addiction, that part of the brain is under functioning. And our so called lizard brain, our fight or flight response, is over functioning. So essentially, people's ability to make rational decisions with addiction is impaired. We look phenotypically normal when we have addiction, right? So let's say somebody has cancer and they've got a port and they look like they've got weight loss and their hair is falling out. They look sick, and we adjust our expectations of them based on what they look like. Or let's say somebody was born
Hmm.
with Down syndrome. Their face looks different. Their body shape might be different, and we can identify that they have a disability based on looking at them. Most patients with addiction, depending on which addiction and how far along they are into it, look fairly normal. And yet you go, why would you do that? And it's because
Hmm.
their brain's executive functioning is impaired. And because we can't identify it by seeing them, there's a expectation and what actually happens mismatch, which leads to us thinking that it is a conscious decision for them to act this way. And yet it is their disease. They truly can't make the right decisions.
I've never heard it explained that way, and that was so well put. I love that. That makes 100% sense. So thank you for explaining that.
Of course.
Uh, I was also watching a video where you were talking, and it said that actually addiction or substance use is beginning as young as middle school. That really, really shocked me. Is that common? Do you have a lot younger ages coming in? Do you feel like it's getting younger over the years? I would love to hear about that.
So I don't know if you've ever heard of Willie Sutton's Law. He was a bank robber,
I have not.
and they asked him, "Why do you rob banks?" And his answer was, "Because that's where the money is." So I applied Willie Sutton's Law to which students I wanted to go talk to as I began starting to speak to schools and do drug prevention education. And I thought to myself, okay, high school
Hmm.
kids are using drugs. Why do we rob banks? Because
Yeah.
that's where the money is. Let's go to high schools because that's where the drug use and alcohol use is starting. So I'd go to
Hmm.
schools, and yeah, there were some kids I connected with. But my spouse and colleague, Dr. Close, and I went to one high school, and one of the teachers came up to us afterwards and she said, "I am really sorry, doctors. They were dealing drugs while you were talking." And what we were
Oh
realizing
my gosh.
is we were missing the window as to when it was actually a time to do prevention. I mean, there are kids when I go to high schools that know as much or more about drugs than I do. Like, they are
Wow.
all into the novel research chemicals, and I'm just like, how do you know this much? How do you know about dimethyltryptamine? Like, you're 15.
Hmm.
So what we realized is that we needed to go backwards. And I
Hmm.
always ask my patients when I meet them, how old were you when you started using drugs and alcohol? And the most common answer I get is between 11 and 13. My patient from an hour ago started drinking beer at 12. The youngest I have ever heard is around 6. I've had a couple of patients that at very young ages like would find substances around the house and try them. And this is a
Hmm.
fundamental part of understanding why addiction happens. So if a person
Yeah.
starts using drugs and alcohol before the age of 13, they have about a 2/3 chance of developing addiction. If they start using drugs and alcohol at 21 or older, that percentage drops to less than 10%. Essentially, the way I describe it is the brain grows differently when it is exposed to substances, which
Yeah.
that's one part. The other part is that the brain develops an association between the substance and a solution. So
Hmm.
there's an author named Nick Sheff. There was a movie a few years ago that came out called Beautiful Boy about a dad's quest to save his son from addiction. That dad's name was David Sheff,
Yeah.
and his son is Nick Sheff. And Nick's written a couple of books. Nick started using cannabis like 12 or 13, and he describes in his books that cannabis fixed everything. My parents are going through a divorce and I don't feel good. I'll smoke some cannabis. That'll make me feel better. I had a bad grade on a test. I'll smoke cannabis. That'll make me feel better. I had a good day. I got a great grade on a test. I'm going to use cannabis to celebrate. My girlfriend broke up with me. I better go smoke a bowl. And what happens is when
Hmm.
people start using alcohol or drugs regularly, we find that their social and emotional learning stops at that age. When they get sober,
Wow.
they're behind and they have to catch up. So we find these like 32-year-old, 13-year-olds, they didn't
Hmm.
actually have to face difficult situations. They didn't have to learn to regulate their emotions when they're having a conflict because the substance was always the brain's answer. And so, unfortunately, it's really hard to stay sober when you don't have those social and emotional tools to deal with regular life. I'll give you two examples.
Yeah.
For me, I learned recently from my therapist, who I mentioned is awesome, that I have generalized anxiety
Hmm.
disorder. And that explains
Hmm.
so much of why I felt so socially anxious as a young man. And I went off to college, and everybody's being social, and there's loads of beautiful girls that I want to talk to, and I just can't. And I felt so uncomfortable in my skin. And one of my friends said, "Grover, I know what you need. You need beer. Beer will fix everything." And so, sure enough, I went out with my friends and they gave me a couple of beers, and it just seemed easier to talk to girls. And I was like, great. And then I don't know how my 18-year-old brain figured this out, but that was like, I probably need to actually learn how to talk to people without beer. And so my sophomore year
Yeah.
of college, I didn't drink anything for about 6 months and just had to deal with the discomfort. Alternatively, I have a gentleman who's my colleague. We have a nonprofit here in Monterey County called Central Coast Overdose Prevention. We also do work in the county to the north, Santa Cruz, and the county to the east, San Benito, to work on overdose prevention, educating our community, and advocating for the treatment of addiction. And he is 2 months short of 2 years sober. He is about a month younger than me, and his drug use started pretty regularly in his teens. And he's going to be 42 this year, and we've had to teach him email, Zoom, banking,
Hmm.
taxes, troubleshooting difficult circumstances, conflict resolution. He is an awesome human being, but he missed those years of social and emotional growth because of his addiction. And so we really supported
Yeah.
him. Like, we literally helped him with his taxes this week. And it's that level of support that's really needed to treat addiction. 30 days in a residential treatment, off you go, often doesn't work because there's that gap in the social, emotional, and life skills learning that really needs to happen in late teens and the 20s.
Yeah. Thank you for sharing that. That's really interesting. And it makes a lot of sense. It's so nice to hear these things explained in this way, which you typically don't. And it's nice to just hear the understanding behind it. So,
Again, this is all
you
really.
talked about,
Go ahead.
yeah. No, I was just going to say, when you talked about, being in the high school and those kids knowing more or the same level as you do about the drugs, I'm curious, how did it impact your practice in the ER when you found that fentanyl had entered your community's drug supply?
October of 2019. I can't remember what day of the month it was, but it was a Saturday and my family was in Lake Tahoe. We called it Fentanyl Weekend.
Hmm.
So
Wow.
we had started working on overdose prevention in Monterey County, where we practice. That's my colleague and wife, Dr. Close. She and I started this effort in Monterey County in 2013. And at that time, Monterey County was in the top third of California counties in terms of opioid overdose deaths per capita. So we were a county where there was a lot of overdose deaths compared to other counties. 6 years of work had gone into overdose prevention, advocating for Suboxone treatment, advocating for addiction treatment, drug education prevention, naloxone. We've done all sorts of stuff. And by 2019, we had the second lowest overdose death rate per capita of all counties in California. So we dropped like
Amazing.
30 counties. And I
Yeah.
hadn't given naloxone in the emergency department for like 18 months. Like,
Wow.
I just wasn't seeing drug overdoses the way we were before. Granted, we were still seeing meth and we were
Hmm.
still seeing alcohol and other substances, but just, it was amazing. Like, I was almost thinking like, we won, we did it. And then October
Yeah.
2019, we got fentanyl and we had 10 overdoses in our emergency department in a weekend. And we were up in Lake Tahoe as a family on vacation, and just our phones were buzzing of my colleagues in the emergency department just saying, something is wrong. This guy took a half a Percocet and needed 3 doses of naloxone. And that's when it hit
Yeah.
us. And it changed everything. Fentanyl is a fundamentally different opioid in what it looks like with addiction compared to prescription opioids or heroin. It is much more difficult to treat. Common treatments like methadone and Suboxone don't actually work as well. It is
Hmm.
unfortunately, a horrible game changer. I am going to say this, and I
Yeah.
don't actually mean this, but I'm going to try to make a point. Can we please have
Yeah.
heroin back? Oh my gosh, heroin was so much easier to treat than fentanyl. And I obviously don't
Yeah.
want heroin back, but from an addiction standpoint, getting people on Suboxone and methadone when they were using heroin was like easy peasy. Fentanyl is so much harder. So fentanyl has changed the protocols, changed the way we treat people's withdrawal, changed the dosing regimen of methadone, changed the way we start Suboxone. We've flooded our community with thousands and thousands of boxes of naloxone. Kids are now aware of it. I went to one school the day before Halloween, and those kids were so scared they were going to get fentanyl in their Halloween candy. The one good thing
Hmm.
I can say about fentanyl is that it has made the conversation in society in America around addiction more front and center, and it's got addiction more attention. That's
Hmm.
the one good thing I can say that's come out of it.
Yeah. Absolutely. It definitely does need a lot more awareness. So, um, I'm curious, so there's providers in a bunch of different specialties that'll come across patients with addiction. What is one thing you can recommend to any provider to better support patients with addiction?
Be nice. I lecture professionally on the topic of stigma. Stigma being
Hmm.
that a person is judged based on an attribute. And in medicine, we as healthcare providers judge our patients all the time. Epilepsy,
Hmm.
incontinence, dermatologic conditions, mental health, suicidality, addiction, obesity. There is an association between feeling stigmatized and mortality. People who are
Yeah.
stigmatized are more likely to die. There was a study looking at weight stigma and stigma around obesity, and patients that identified as receiving stigma about their weight were more likely to die in the study period compared to those who weren't. So stigma
Wow, that's
kills.
powerful.
Yeah, stigma kills. I don't know how else to say it. I'll give you an example, and I may get a little
Yeah.
emotional during this. So again, my lovely spouse and colleague, Dr. Reb Close, was working at a syringe exchange, and one of the guys who worked at this, one of the guys who worked at the syringe exchange, his name was Mike, and Mike was using opiates and injecting them, and he was actively trying to help his community. He was trying to hand out clean needles, wound care kits. He was trying to help his fellow community. So he was obviously aware of the need to treat addiction, and unfortunately, he developed a infection on his arm from injecting, and he went to my spouse and colleague, Dr. Close, and said, I've got this infection. I've got a fever. Can you help me? And ER docs know injection drugs plus fever is a 3-alarm fire. And I see you nodding, right? Healthcare providers.
Yep.
Is it a heart valve infection? Is it a bloodstream infection? And she literally told him, will you please go to the hospital? This could be bad. And he said, no, they're going to judge me. They're going to treat me like dirt for my addiction. I am not going to go to the hospital. And she was just flabbergasted. Like, these are my colleagues in the ER. Like, I will go and be there with you. I will talk to my colleagues. I will advocate for you. And he was like, nope, I don't deserve to be treated like garbage. I will not go to the hospital. And he died of stigma when he died of sepsis.
Wow.
Our patients will thank us for making eye contact with them. They will thank us for shaking their hands. Of all of the conditions I researched when I was developing an expertise on lecturing about addiction, the most stigmatized condition in America and likely the world is addiction. And why? It goes back to that idea that people look at a person and can't understand why they make the decisions that they do. And the gap between what they expect and what happens, that's where the judgment comes in because they don't understand. I have joked many times that addiction medicine, I could train my dog to do it. You walk in, you wag your tail, and then you arrange follow-up. In other words, we have to create a safe and accepting we have to create a safe and accepting space for our patients, for them to be open to the vulnerability that is required for them to actually get treated for addiction, right? If you think about it, at the most fundamental, treating addiction is teaching patients to stop using chemicals and substances to regulate how they feel and learn how to regulate themselves. And if you can imagine, if you got sexually assaulted starting at age 2, and you have horrible PTSD, and fentanyl makes it not so bad, getting off of fentanyl is going to mean facing that PTSD. And if your healthcare provider judges you, you are not in a safe place to process that PTSD.
Yeah, that story is really impactful. Nobody should be dying of simply, stigma. So thank you for sharing that. I really appreciate it. And, I think we can all do better, even as humans, to not judge others, but especially as healthcare professionals. So I know earlier you mentioned journaling in the morning. Are there any specific like books, habits, or routines that have impacted you as a physician?
I'm actually amazed I've made it this long without journaling. It's very therapeutic.
Okay.
So every
Yeah.
morning I get up at 5. I mentioned I'm not really a morning person, but that's my time to exercise. And so my dog and I go out for a walk, and I just start dictating into my iPhone what's on my
Yep.
mind. This morning I have a very, very difficult patient. Not that she is difficult, but that her situation is very complex, and I'm trying my best to find out how to help her. She's a lovely human being with a very, very difficult set of clinical circumstances: PTSD, chronic pain, multiple surgeries. And I was just kind of at a loss yesterday after I talked to her. And so this morning, I just started free associating and just kind of let some of my emotions come out and some of my thoughts. And I was actually able to come up with a fairly good treatment plan. And I talked to her this morning, and we made some changes to her meds, and we're going to see how it goes. Sometimes I get really triggered. I have one patient who was sexually assaulted at a very young age, and I've broken down in tears a couple of times in visits with her just because she was never really given a fair chance, and she's been sexually assaulted too many times to count. And I, a day after seeing her, sometimes have to just talk through my emotions. And my dog is there, and if I need a minute, I'll kneel. And I'm a big believer in emotional support animals, and I'm very liberal with writing emotional support animal letters for my patients. And I'll kneel and just kind of focus on my animal and just be close to her and try to reset my emotions and move on. But I actually don't know how I made it this long without journaling, and I would guess that's probably a contributor to my PTSD. is that I had
Hmm.
all this negative emotion that didn't go anywhere. And so it led to my brain changing as it hadn't processed those previous traumas.
Hmm. Yeah, I definitely recommend journaling as well. I love it. I'm a big, big fan of journaling and of animals as well. My
Mhm.
dog is like my child. She's laying next to me snoring right now. So they're great. They get it. You can talk to them. They won't talk back to you. So definitely recommend journaling and animals. And if you were to give advice to, other physicians, what is something that they can do to improve their mental well-being as their, let's just say like an emergency physician who is going
Mm.
through all of these difficult scenarios? Any advice there?
Don't just shove it down and move on. So I think
Yeah.
we as healthcare providers, we gravitate towards healthcare because we want to give, we want to help.
Hmm.
And it is amazing to me how selfless we can be. We'll skip our lunch breaks. I know I have to pee, but that patient needs me to sew them up. I know I'm
Yep.
hungry, but my patient needs their Zosyn. We put our patients in front of ourselves, and I commend all of us for doing that. But if we don't
Hmm.
acknowledge our own mental health, it does become a problem. I was really taught
Yeah.
as an emergency physician is when bad things happen, we go on to the next patient. And I'm really grateful. I mean, my spouse was also an emergency physician, so I would come home and just be like, Reb, I have got to debrief. I had a horrible case. She would drop what she was doing and give me 5 minutes and just let it all come out. And I'm very lucky. I actually don't
Hmm.
know how I would have made it this far in my career without my spouse. And
Hmm.
her back to me. She'd come in with tears in her eyes and be like, I had the worst case today. And I'd stop what I was doing and I would give her that safe space. I can think of a colleague from residency, and he actually just wrote an article about this, but he was participating in the care of a perimortem C-section during residency. And just to level set what that is, a woman is dying, and we cut her open and deliver the baby. It's very different than obviously in the OR. It's basically a last ditch effort to save the baby before the mother dies. It also actually,
Oh.
if the mother is dying, her chances of survival go up with CPR if the baby's out of her system because it's less blood volume and right. So
Hmm.
he had a woman come into the emergency department while he was a second year resident in full cardiac arrest, and they did a perimortem C-section, and he was involved with that. And then he had to go finish his 12-hour shift. I don't know how he did it. And I was really pleased to see he was writing about it. I mean, he literally just published an article like 2 months ago. I reached out to him and just
Yeah.
said, you are a strong, you have more strength than I ever could for being able to do that."
Hmm.
And his own processing, I'm sure he's done it and worked on it. I had cases that were not quite that harrowing, but I took care of a 2-year-old that was killed by a large piece of wood floating in the ocean when a wave broke and crushed the child. Like it just weighs on us. So, and I keep giving these long answers. I am so sorry. I will try to be more brief. The answer is that we have
No,
to
it's okay.
realize that as healthcare providers, our mental health matters too.
Absolutely. I totally agree. I really resonate with the fact of, well, I can't go to the bathroom because I have to, keep going for my patients. As a nurse, that is so common, unfortunately. The amount of days where I didn't sit down for the entire 12 hours, far too common and not great for anyone. You need to take care of yourself as well. So I really agree with that. And also just having someone at home, like you said, a spouse that you can come home to. My husband is also, he's actually in residency right now, but he was in medical school when I was at the bedside as a nurse. And I would come home and just have a 5-minute cry session, let it all out. And that was really nice to have someone at home where I could just let it all out to. And even if it's not someone at home, a friend, it's really important to find community who understands what you're going through.
Totally agree.
Well, I would love to hear anything exciting that you're working on for your podcast or your work in California.
I think I'm finally at a point in my clinical career that I feel like I understand addiction. And I hope that's something that
Hmm.
we've talked about today is the why. I was always the medical
Hmm.
student with too many questions. Like, well, why does this happen? Why do we do this? Why do we use drug A, not drug B? I actually totally annoyed my medical school classmates. I had a reputation for always being that one annoying med student that had more questions. So my apologies to my med school classmates for having to deal with me. But I finally feel like I understand the why. And I am
Hmm.
now starting to really work on trauma and the intersection between trauma and addiction. And it's something that I am trying to think outside the box in terms of how to support patients, realizing that there's so much more to treating addiction than the medicine. So I'll give you an example.
Hmm.
We just put together a support group in the evenings in our office, which isn't 12-step based. It's truly just meant to create a sense of community.
Hmm.
We are doing CrossFit with our patients, and they don't identify as patients in CrossFit. We identify them as just
Hmm.
somebody who's interested in supporting our nonprofit. But that community. So last night we were doing box jumps and pull-ups and what was it? Hang squat snatches with one of our patients. And it's just that sense of community. My mom's a local tennis pro and runs a big Sunday morning tennis clinic, and some of my patients come play tennis. They get to be accepted and part of a group for 2 hours on a sunny Sunday. And I think if anything I've learned, it's that addiction really involves seeing the whole person and trying to create positive human interaction. So I'm going to go on a little tangent here. We have three basic needs as human beings, right? So we need food, we need sex because we need to make babies, and we need human connection.
Hmm.
And so if you think about these are basic survival skills. Human connection, we created villages that gave us safety. So we have an inherent need for human connection. And those three things, food, sex, and human connection, all release the brain chemical known as dopamine, which gives us pleasure. Addiction largely involves that dopamine system being hijacked by the substance and artificially raising those dopamine levels outside of those three basic things, right? Alcohol,
Hmm.
cocaine, cheeseburgers, pornography, it all hijacks that dopamine system. And so as people come back from their addiction, they need dopamine to just even feel a little bit normal. And that positive human
Hmm.
connection is so incredibly powerful. When someone gets a hug, their dopamine goes up naturally. When someone gets a high five because they hit a good shot on the tennis court, their dopamine goes up. And addiction is a very isolating disease. Consequences, broken
Hmm.
relationships with family members, divorces. And I think what I'm just trying to do, again, a long answer when I promise to be brief, is I'm trying to incorporate positive human connection as a specific therapeutic modality as a part of my treatment.
That's amazing. I love that so much. It's a great initiative, and I'm a big fan of exercise, like I said. So that's really, really cool. Um, and you mentioned, when you were a medical student, what is one message that you want medical students or brand new providers to hear?
I think it goes back to being nice. It is really, really easy to judge. And I think the best
Hmm.
question a medical student can ask themselves when they start to feel themselves judging a patient is stopping to ask not what's wrong with this person, but what happened to this person. There's a life story.
Yeah, absolutely. Well, thank you for all that you shared today. This was so, so amazing. It's definitely going to impact a lot of healthcare providers. So I really appreciate your time. I will love to hear where can people tune into your podcast or support the work that you're doing in Monterey County.
I really appreciate you allowing me to give shameless plugs for the work I'm doing. So thank you. My addiction podcast is called Addiction Medicine Made Easy, and it's on whatever podcatcher you use. I do have a website. I can't even remember the website. Good heavens. I think it's addictionmedicinemade.easy.com. Hang on just a sec. You can see how much I use my website. Addictionmedicinemade.easy.com. There we go. And then our nonprofit is called Central Coast Overdose Prevention. So if you put that into your search engine of choice, you can find that. But I think what's really cool is that people's attitudes about addiction are changing. And if there's any silver lining to fentanyl, it's that we are starting to realize that this is a urgent issue, and we're tired of losing people to addiction. About 105,000 Americans die every year from drug overdose. Last I heard, 195,000 Americans die from alcohol every year, and about 450,000 Americans die from tobacco products every year. That's a lot of people. We have got to do better.
Hmm. Absolutely. Well, you're definitely making a positive impact with, teaching about it and just transforming the space. So I appreciate the work that you're doing. I appreciate you being a guest here on the podcast, and I look forward to hopefully talking again in the future.
Absolute pleasure. Thanks for inviting me.